All, I'll be speaking in this video on how to interpret the antibiotic susceptibility test report. Take the example of the present case study where blood culture yields Enterococcus faecalis. Antibiotic sensitivity report is as follows, where many antibiotics are sensitive. Then the question arises, which antibiotics will you use? Ampicillin, daptomycin, penicillin, vancomycin, all are sensitive. So in such, always refer to the 4 rules that we discussed in the previous session. Rule number 1, always start with the beta-lactam antibiotic if possible. Rule number 2, do not compare MICs between drugs. Rule number 3, if antibiotic is sensitive, you can still use the drug, but with some exceptions. And rule number 4, microbiology always has some information, so refer to the microbiology testings. So for the present case study, where many antibiotics are sensitive, ampicillin, daptomycin, penicillin, and vancomycin, apply the rule number 1, always start with the beta-lactam if possible. So the drug of choice will be, for this ampicillin sensitive enterococcus will be ampicillin. Rule number 2, do not compare MICs. Though daptomycin and vancomycin are sensitive, but still ampicillin will be the drug of choice. Rule number 3, if it is sensitive, but consider some exceptions. So consider the cost effectiveness, ampicillin will be drug of choice as compared to vancomycin or daptomycin. Rule number 4, microbiology has more information. Then you can refer to additional testings such as linear testing, which is the only oral option, but still prefer ampicillin will be the drug of choice. So this is how we can resort to this 4 rules while interpreting the sensitivity reports. Let's take another example. Urine yields Klebsiella oxytoca, and it is an ESBL producer. It is mentioned in the microbiology report that it is an ESBL producer, that is extended spectrum beta-lactamase, that is it is resistant to third generation cephalosporins. So here only antibiotics, the antibiotics that are sensitive are cefotetan, and then levofloxacin, meropenem, and intermediate is the peptide, and tigecycline sensitive. Then which antibiotics should you use? Before look into the question, let's understand further more factors such as, is it cystitis or pyelonephritis? If cystitis, male or female, and if female, how old? Let's assume this is a cystitis. It is a young female with no comorbid condition. Then another question, do you want IV or per oral? Let's take help of these 4 rules. For this particular case, always start a beta-lactam antibiotic. Now it was a ESBL producer, so still third generation cephalosporins, all antibiotics will be resistant. So though cefotetan is reported as sensitive in the report, since it is an ESBL producer, it won't be the drug of choice. Cefotetan and meropenem are the only sensitive beta-lactam, so cefotetan won't be the drug of choice. For deciding whether meropenem can be used can be used for this particular case, consider the rule number 2. Do not compare MICs between drugs. So meropenem is appropriate, but it is IV. So even if it is sensitive, or applying rule number 2 and 3, we will avoid meropenem. Second is ciprofloxacin is resistant. So though levofloxacin is sensitive, it will not be used because of the factor of cross resistance. Other thing is tigecycline is sensitive, but tigecycline has poor urine penetration, and it is IV too, IV also. So tigecycline will not be selected. So we are left with the only sensitive antibiotic, that is nitrofurantoin. Again, rule number 4, to refer to addition testings of microbiology. So fosfomycin can be tested, but again fosfomycin is expensive, so our drug of choice will be nitrofurantoin. So this is how we can apply all 4 rules while selecting the proper rational. Take example of another interesting case study. A 67-year-old smoker with fever and cough for 1 week. Presence with high temperature, increased respiratory rate, no travel abroad, no pets, works as a salesman. Which all the tests will you send for this case with a respiratory tract infection? Take about a few seconds and let's see the answer. The answer will be CBC, CRP, kidney function test, urine dipstick, and chest X-ray. CBC, because it gives information. CBC, that is full blood count or complete blood count. It gives complete information about the likelihood of infection. With a neutrophilia indicates likely bacterial cause, and platelets are indicators of infection and inflammation. Hence, the complete blood count was done. Urine and electrolytes or kidney function test was done to see the assess the renal function. Urea can also help us to assess severity of community acquired pneumonia. Increased CRP indicates bacterial infection. Urine dipstick has 97 negative predictive value for UTI, hence urine dipstick was done. Chest X-ray is a part of this thoracic criteria for community acquired pneumonia. Hence this test was done for this particular case. On chest X-ray, it has revealed signs of consolidation. WBC level was high, urea electrolytes were high, CRP was high, urine dipstick was positive for leukocytes, and chest X-ray showed signs of consolidation. Then what is the diagnosis? High few seconds. The answer is community acquired pneumonia. Why not UTI? Chest X-ray showed right basal consolidation, so the diagnosis of community acquired pneumonia. Dual pathology is very rare, so it is unlikely for the patient to have both pneumonia and UTI. Even though the urine was consistent with diagnosis of UTI, but the positive predictive value of this test, that is dipstick test, is very poor, and so does not diagnose UTI. WBC suggested an acute bacterial infection, hence the diagnosis of community acquired pneumonia. Now the patient is signs of pneumonia, and which is of this following is not a sign of community acquired pneumonia? Is it crackle, dullness, or increased resistance, or reduced chest expansion? Have few seconds. So the answer is crackles. The clinical findings which are consistent with the consultation are decreased chest movement, decreased chest expansion, that is decreased vocal resonance, dullness, increased breath sounds. Crackles are signs of heart failure rather than consolidation. So was the answer crackles. Further investigation done for this case study was sputum culture, blood culture, urine for lesional antigen. If this sputum appearances is considered with the diagnosis of community acquired pneumonia, whether it is mucoid purulent, salivary, or mucopurulent. So the answer is purulent. Appearance of sputum helps in distinguishing infection from contamination. Salivary appearance of sputum often indicates contamination. Mucoid appearance is indicative of upper respiratory infection. Purulent means it indicates inflammation and therefore is considered with diagnosis of pneumonia. Here the patient deteriorates, the saturation decreases, temperature increases, HR rate, heart rate increases, respiratory rate increases, the patient starts having rigors. Antibiotics really use peptide gentamicin or peptide clindamycin, coamicicloclarithromycin, or teicoplanin or levofloxacin. Have few seconds to think. So the answer is coamiciclo plus clarithromycin. Most hospitals use a combination of a beta-lactam antibiotic and a macrolide antibiotic for severe community acquired pneumonia. Piperacillin tazobactam is unnecessarily broad spectrum. Gentamicin doesn't penetrate into the chest cavity and doesn't have any actions against non-culturable bacteria. While clindamycin is often considered with the macrolides, but it is it is actually a lincomycin and has a different spectrum of activity. It doesn't have any action against non-culturable bacteria. Hence, the drug of choice is coamiciclo plus clarithromycin. Again, if you see teicoplanin levofloxacin, which is often used for severe community acquired pneumonia. So, however, this patient doesn't have any evidence of any allergy. And again, teicoplanin levofloxacin will be used for who are allergic to beta-lactams, but this patient didn't have any evidence of any allergy. So, the drug of choice was coamiciclin clarithromycin as compared to teicoplanin or levofloxacin. The patient is diagnosed with community acquired pneumonia. He is on coamiciclin and clarithromycin. His curve score 65 score is 4. Now, the following is not a cause of community acquired pneumonia. Is Legionella, Streptococcus, Pseudomonas, or Staphylococcus? Which of this is not a cause of community acquired pneumonia? The answer is Pseudomonas. Pseudomonas is a cause of healthcare associated. The common cause of community acquired pneumonia is Staphylococcus aureus, Streptococcus pneumonia, Mycoplasma, Haemophilus, Legionella, Chlamydia, and viral causes. Pseudomonas, as said before, it's a cause of chronic obstructive pulmonary disease and healthcare associated. The blood investigation reveals the next day that WBC still rises, CRP rises, and conditions further deteriorates. Culture of urine doesn't yield any growth. Blood cultures yielded a gram-positive cocci growth. How will you manage this patient? Whether you will change his coamiciclin to peptides or change clarithromycin to levofloxacin, stop the antibiotics and start meropenem, or persist with the same treatment. Have few seconds to think. So the answer is persist with the current treatment. There is no reason to suspect that this patient has anything other than community-acquired pneumonia. So it is most likely that the patient needs more time to respond to the treatment, and he might need some as more respiratory support like oxygen or non-invasive ventilation. Dropping the macrolide antibiotic like clarithromycin will be a mistake, as it just means that the uncultured bacteria are no longer covered. So persist with the Comex, Clev, and clarithromycin. The results were followed after 2 days. Urine no growth, blood culture yielded contaminant growth of Coagulus negative Staphylococcus, sputum yielded Streptococcus pneumoniae, while the urine was positive for Legionella antigen. It is Legionella pneumonia or Streptococcus pneumoniae or aspiration pneumonia or Staphylococcal endocarditis. Have few seconds to think. So the answer is Legionella pneumophila pneumonia. Why so? Patient was diagnosed as Legionella pneumophila pneumonia, and the urine antigen test is a very good test. Is a high sensitivity and specificity. The drawback is it doesn't detect it does all the serogroups except serogroup 1 only, but that's the most commonest. Growth of Streptococcus pneumoniae and sputum can occur as is part of a normal respiratory flora. A Coagulus negative Streptococcus from the blood culture is a contaminant. Hence, the diagnosis of Legionella pneumophila pneumonia. What is the treatment for this Legionella pneumophila pneumonia? Meropenem, Coamex, Cortimation, or levofloxacin? The answer is levofloxacin for 3 weeks. Levofloxacin is always superior to clarithromycin for a treatment of Legionella pneumophila. The mortality rate decreases from 10 to 0.5%. Levofloxacin has a very good oral bioavailability. So if the patient is showing signs of improvement, it is really necessary to give it by the IV route. So oral route will be preferred. Hence, oral levofloxacin for 3 weeks will be the treatment of patient was converted to oral levofloxacin and continued for a 3 weeks treatment. He made a full recovery. However, the source of Legionella pneumophila was never found. So that's how we make use of the 4 rules of microbiology while interpreting a sensitivity report. That's how we should refer to the clinical signs and symptoms, make use of pharmacokinetics and pharmacodynamics and the clinical correlations to interpret a sensitive report of microbiology. Thanks all of you, and in the next session we will see how to interpret the antibiogram of an hospital and use it to formulate an antibiotic policy. Thank you.